Okay. Assalamu alaikum. Good morning, ladies and gentlemen. And I would like to thank the organizing committee for our second SACIS forum for this invitation and welcome our guests from outside the kingdom. My case, I like this case because I still see the patient in the clinic. We'll start by the case presentation. He's a 27 years old Saudi male patient. He presented to us in 2002 with inferior STEMI. His risk factors at that time, he was a smoker and he is hyperlipidemic. He had no diabetes and no family history. Immediately, patient was diagnosed in emergency department in that year and he was transferred to the cath lab. We did for him a primary PCI of his RCA, and I used a drug-eluting stent at that time. As you can see here, this is his right mid total occlusion. It's a very ugly. You can see the hanging of the dye full of thrombus. We use a aspiration device and the stenting as usual. And as you can see, you gave him some intracoronary repro at that time. And you can see the final result after that. Did the left side, you see almost a double LAD, like the diagonal parallel and long, same size like the diagonal, a true bifurcation involving the ostium of the diagonal and the LAD before and after the bifurcation. It's true bifurcation in addition to a mid-tight lesion after the bifurcation. And this is another view. You can see two lesions in addition to the bifurcation itself. And this is the LAO view. You can see a very, trying to find this, I don't like this color, anyway. Okay, what I did at that time, I did the primary PCI of the right. Then I said, I think the best choice for this patient is to stage him for, and his file is belong to National Guard. He's one of the relatives of one of the employee in the National Guard, and we know for sure such patient they will not go to other hospital. They live in the same area of National Guard, and I think we are lucky. Like I'm seeing this patient since 2002 till this moment. The plan was for staging of his LAD diagonal bifurcation, and he fits in this category of Medina classification 111. And if you thought about it, it's typical like Y shape, and the mechanism or the way of treating the bifurcation in this patient, he can fit in those either a crush or mini crush or keloid, and that was in 2002. Recently we are doing the tab technique, which is almost equal or sometimes easier. And if you can see here, I think that was my approach in this area. Okay, that's it for now. Thank you.